Hi everybody, welcome back to my channel. If you're new here, welcome in. If you're coming back, I'm so glad to have you. I'm Stacy, I'm a registered nurse, and I like to talk about my life in scrubs and my experiences. I think we should talk today about a little bit more about wound care because that's a topic that I really love. And I think we should expand upon that topic a little bit more because I have more to give. Let's talk about the wounds that are not healing. And we're talking about it from a hospice standpoint, but we can also talk about it from a facility standpoint. I worked in long-term care. I did wound care, and I think that we had a lot of great treatments that I don't see anymore. And the reason that I don't see them anymore is because it's costly. Now, I want to tell you, if a person experiences a wound and it becomes your fault that they experienced that wound, your company has to pay for those wound care supplies. It's not covered by insurance. If they come to you with a wound, say you found a wound on admission, or it was reported that they had a wound, they have a surgical wound, they have a wound vac, they have some need for a wound, it's not your wound and insurance is going to pay for those supplies. Is the way that it was explained to me when I was a wound care nurse. So you really don't want those wounds to develop in-house on your watch because your company has to eat that cost. And that's when I learned about the cost of wound care supplies. And in management roles, I've learned about the cost of wound care supplies. So they will find the cheapest solution to fix the problem. A lot of times. We used to do a lot of wet to dry dressings. Let's be real, that's not the best treatment for everything, but that was the thing. That was the thing that we did in the early 2000s. We did a lot of wet to dry dressings. We had things like Santil, Panafil, Zenoderm. Those were the brand names that came out. They came out with, it was a pink foam, and now I can't think of the name of it because it's been forever since I saw it. They came out with the pink one, they had the silver one, then they started coming out with thicker foams. We had Duoderms, we had all kinds of dressings that were designed to do different things. Let's talk about that. Let's talk about it. Alginate was around when I was fresh into nursing, or at least halfway into my LPN years. When I was doing wound care, we started seeing other products like alginates. They were big on the market. And we were taught how to use those dressings and how long they should be used for and what we should be using them for and how we should be using them. So Panafil was it was green and it was a mild debrider. And it had plant material in it, and it was supposed to be gentle and for your wounds that had some slough in them, not for your heavy wounds with eschar. We also had Santil was a step up from Panafil, and that was in that company's debriders, Panafil and Santil. I think I still see Santil every once in a while, but it is pretty costly. It's pretty costly. And we used Zenoderm for things like moisture-associated dermatitis, MASD. You'll see that sometimes when you're doing wound care. That is where the bottom is breaking down, but it's not necessarily from pressure. It's more from having moisture against the skin. And the Zenoderm ointment had stuff in it that was healing and protective. And it was amazing, and you couldn't get it unless somebody came into the facility with a wound because it was just so costly. And they didn't have generic alternatives for these medications. Santil is like an enzymatic debrider. It's for your heavy eschars and things like that. We had wound care nurses, nurse practitioners, and doctors that would come into our nursing home facilities. And they would debride the wounds because when you remove that necrotic tissue and you get those edges fresh and not rolled in, the skin can begin to crawl across the wound and grow together. And that's what happens. The skin cells form. We learned about things like biofilm that gets on the wound that you need to clean out of the wound. We also learned about, protecting the wound's own environment. You have dressings that are made to help the body's own enzymatic processes work. Duoderm was one of those products that they marketed for that. I will tell you that it's one of those things that you want to be careful with on fragile skin because people have a tendency to want to change dressings every day. And the thing is, these wound care products were marketed to and made to decrease the amount of dressing changes that you would need to do and allow the body to have healing and form its own environment. And people cannot wrap their mind around leaving a dressing in place for 3 to 5 to 7 days, depending on the drainage, exudate. People want to change a bandage every day. Well, if you're going to do that, you may as well use gauze and tape, because you are not going to get benefit from those special dressings if you're going to take them off every day. The other thing is, if people are incontinent of stool and urine, sometimes those dressings are not going to hold, especially on a sacral, coccygeal, buttock type wound, or, in those ischial areas under the butt cheeks. Those wounds are going to be hard to maintain a dressing on. I'll tell you though, those foam dressings are amazing if you get a wound on the hip, in the trochanter. They're also really good on the insides of knees, and they have really good ones that are used for heels that will stay in place if there is not a lot of drainage. When you want to change those foam dressings is when they have, I believe it's something like 75% exudate on the bandage. So you're looking at the bandage, you can mark it with a marker to see how the drainage is. If the dressing's intact and it's not soiled, you can leave it in place. You shouldn't be taking it off. Sometimes families want to see what's under there. And in a home hospice setting, a lot of times families will change that dressing daily, and you really have to give a lot of education about leaving the dressing in place if it's intact. Because when we're pulling a dressing off too, if we're not careful and the skin is fragile, it's going to create other problems. What I've seen happen with Duoderm especially is that people will pull it off and take the skin right off with it. Duoderm is really good for those people that just don't have any meat. They don't have any fatty tissue on their body. I will tell you that I have seen the types of people that break down are going to be your skinny, bony little people that don't have any extra adipose tissue, any fat on their body. Heavier set people are a little bit more well nourished, and they don't break down as easily. In my experience over the years of seeing wounds, bottoms break down when there's no fat back there. And Duoderms add a little layer of cushioning sometimes, especially in that tailbone area. That's where I love using a Duoderm. Again though, if it's somebody that's heavily incontinent and the dressing's not going to stay, you shouldn't use a Duoderm. It's not going to benefit you. And you should also know how to put one on and take one off safely. We have products that are called skin prep, and then there's adhesive remover that you can use on the skin. It's like an oily, it looks like an alcohol pad, but it's got oil based in it, and you rub it around until it takes the wound off. If you're doing a gauze based dressing or an ABD or something like that, if it's sticking to the wound, you can use normal saline to soak that wound dressing and get it off, because you don't want to be pulling a dressing off of a wound. That might disturb the healing process in the fresh epithelial skin cells that are growing there. So you want to think about how you're putting them on and how you're taking them off. Skin prep is a really beautiful thing to use. Another type of dressing or product that we don't think about are ostomies. Ostomies and wound care can kind of go hand in hand, because it's a product that's sticking to the body, and you need to protect the skin. When we're talking about stool or urine coming out of the body in a place that we're not used to having it, and there's an opening there, and urine is sitting against the skin or stool is sitting against the skin for even a short period of time, that can be really acidic and irritate the skin. So you want to think about using protective things like skin prep. And they do make skin prep that doesn't sting. And I will tell you, I've put skin prep on myself just to see how it feels, and it hurts like the dickens. So I would recommend using non-sting skin prep on anybody and everybody, because that other stuff, it's really only for skin that's not open. If you put it on skin that has any opening area and that stuff gets in that wound by inadvertently, it's going to hurt, and it's going to hurt a lot. I don't know if you've ever, when you were little, if your mom ever put alcohol on your skin, but it burns like that. Back to dressings. So an ostomy is similar to a duoderm in the style of products, or similar to like a Me-Fix or that cloth white mesh tape that you get. It sticks pretty good once it sticks. A trick to getting stuff to stick is getting it hot before you put it on the body. If you take a duoderm out and you put it straight on the skin, it's not going to stick. A trick is to put it between your hands and heat it up. So if you're using a duoderm, you want to heat it up before you put it on the skin. And that will help it stick, and it will help it stick really good. If you're using tape, paper tape sticks amazingly on skin. It's really actually pretty good, and it's pretty gentle, paper tape. I don't like silk tape at all for wounds, but if you're sticking it to a bandage, silk tape seems to be okay. I've had silk tape on me. It leaves the stickiness on you. It's very hard to clean off, even with adhesive remover. I love paper tape. It's gentle for people who have fragile skin, but you really want to avoid skin contact with tape on places like arms, where people have fragile skin when they get older and they get skin tears, because when you get sticky on fragile skin, it's going to pull the skin with it when you take it off. So I would recommend that you're being gentle with removing your tapes, that you're using products that help take the adhesive off. But then once you use those products, you also have to get the skin clean and free of those oils in order to put the new dressing on. So you can use the duoderms to take them off once they're on and they're sticking good. If you pull them at the corners, they release and they come off really a lot better than if you try to peel them down. Just some tricks I've learned, and that works really well with Tegaderm as well. Tegaderm is really good for IV sites. It's good for really superficial abrasions, but I don't really like Tegaderm for wounds. I mean, you've seen what it does in a tattoo. It kind of bubbles up and it gets the stuff inside. I don't love Tegaderm for wounds. I do love Me-Fix, is what that's the brand name. I love that for wounds where you need to use ABDs, or you're using gauze or foam without adhesive. I love Me-Fix. It sticks to the skin. Again, you might want to heat it up a little bit before you stick it to the skin, because the glue activates with heat. It just does. But Me-Fix is one of those things that you kind of want to use an adhesive remover to get off as well. Because when you're talking about fragile skin and people who are compromised nutritionally or compromised, with their skin turgor, they're not hydrated, they have disease processes that are affecting their ability to absorb nutrients, you're going to be more likely to injure those types of skins. So I'd say use an adhesive remover. And if your company doesn't have one, I would ask your supervisor or your manager if it's something that they can bring into stock, because sometimes people just maybe missed it. Or, you can soak a wound off, but it takes a really long time. It really just takes a long time. I love island dressings, the Tegaderm, for different types of wounds. Those types of wounds are good when you're using like an alginate. Gauze has its purposes. I mostly use gauze for cleaning. It's very rare that I've stuck gauze to a wound in a long time, unless a doctor specifically said they wanted a wet to dry, which really should be very minimally wet. Wet to dry really shouldn't be sopping wet when we put it in a wound bed, and it's really not the best treatment, because really what happens wet to dry is that you're pulling good skin cells off sometimes. One of the things that you want to do when you're using products inside of a wound, we use things like honey, which works as a debrider. It works as a bactericidal product. It kills bacteria. And you want to try not to get any of the things that you're putting inside the wound bed onto the healthy tissue, because that can create more skin breakdown and it can make your wound larger. And you want to make sure that you're not packing a wound too tightly. I've talked about this and I could talk about it forever. Fluff, don't stuff. Alginates, they're really good for wounds that are heavily draining. You want to use alginates you can use it in wound beds that have necrosis, but it's really better for a cleaner wound bed with a lot of drainage. But again, you can use honey and alginate together and they work wonderful together. I have seen a wound bed clean up in a week. Because in home care setting, I might be only seeing a wound every couple of days. I might only see it once a week, depending on what the family's comfortable with as far as wound care goes. Some families don't want you in their home 3 times a week messing around. They want to do the wound care themselves. Once you teach it to them, they want you to let them handle it. Other families are like, hey, we do want you to come 3 times a week, and then you get to see the wound gradually clean up. But Meta Honey is wonderful stuff. It cleans the wound bed, and if you put a little alginate in there, I've seen it work wonders. But you have to know when to stop those treatments as well. Honey you can keep on using, but alginates, sometimes you don't need them once a wound is dry. Once a wound is good and dry, you're not getting any benefit from alginate. We used to pack wounds with packing strips and things like that. Mostly I've seen that done in like your surgical wounds that have had, say, an abscess or something, or they healed outside but not inside and had to be opened and healed by secondary intention. So I haven't seen packing strips in my setting, but we used to use iodoform and just plain little packing strips, and you got to be careful with that. You got to know how much you put in, and you got to take it back out. You got to make sure you get everything back out of the wound. We have the long Q-tips for measuring wounds, where you're measuring the length, the width, the depth. We have little rulers for measuring length and width, but once you start going into a wound, you should be using a sterile Q-tip and being really gentle. Don't go poking around there hard. You don't want to damage anything when you're in there. But your Q-tips are going to help you to measure tunneling and undermining and those sorts of things. And you should ask for them if you don't have them, because people should carry them. And then we have products, which are the foams. They have foams that are non-adhesive, where you have to stick them to the skin or wrap them with a dressing. And they have foams that they have the dressing on them. They're like Mepilex and those sorts of things. And those are pretty gentle to the skin, but you have to make sure that the skin is really dry. And I would recommend using skin prep before you put those on and letting it dry so that it forms a good seal. And you want to make sure there's no openings in that, because on bottoms, on tailbones, and in the sacral area, it is really hard to get a dressing to stick, because that area is often not dry all the time. It sweats. There's urine and feces that get in there. Drainage gets down in the crack. Things like that happen. So you want to make sure it's really clean and dry before you put the dressing on, and that you have a good seal. And skin prep can help you to have a good seal with those foam dressings. We also have these really cool dressings that have holes in them that are like a silicone dressing. This is something new that I saw. You can put that over a skin tear, and it can stay in place and protect the wound, and you can clean over it and use antibiotic ointment over the top of it and use a secondary dressing over it. It is really amazing. I had no idea it existed until I came to work in hospice. And sometimes I've seen some really cool stuff. There's TheraBlue. There's different types of treatments for different types of wounds, different types of bacterias. How do you know what type of infection you're dealing with if you're working in a hospice setting? How do you know what kind of infection you might suspect without being able to do a culture and sensitivity? When you're working in a facility, they do things like culture and sensitivity to find out what the bacteria is and how to treat these wounds. I'm just going to tell you that there are things called Proteus mirabilis and Pseudomonas that are very common in wounds. You will know Pseudomonas if you see it. You'll know it. It has a very distinct colored drainage. It looks like robin's egg blue. It looks turquoise. You know that's Pseudomonas if you see that teal, turquoise, robin's egg blue drainage on the dressing. Proteus mirabilis can get into Foley's. It can get into wounds, and you will know it by its odor and its appearance. It's thick and it's stinky, and it's not uncommon in a wound. MRSA happens in a lot of wounds, MRSA. I don't suppose we should call it MRSA. You can get VRE in wounds. You can get any kind of bacteria in a wound. I can't tell you how to tell if it's MRSA, but just assume that anybody could have MRSA. That's why you should always wear gloves and wash your hands and all of those things. If a person is incontinent and they have a large wound, you might be fighting a losing battle. I remember when we started the movement of taking the catheters out and not leaving them in long term. And I remember the doctor who talked to us about it. His name was Dr. Parks. He was a doctor that had been around forever. He was the medical director in lots of nursing homes. And he said, Having a catheter increases the mortality risk significantly, and gave us all the details. And we started taking Foley's out. We started taking indwelling catheters out, and we had to have a good reason to put them in. Wounds that are not healing are a good reason to use a short-term catheter. You don't want to leave catheters in forever because it is a high risk for infection. It is a foreign material going inside of your body, and it does have the risk, if it's not cleaned properly every time, to develop infections. So you have to think about risk versus benefits, and sometimes you do need to put a Foley in. On gentlemen, you can sometimes use those condom casts. They're using PureWicks now. I'm just going to say that I'm seeing things that say that PureWicks are a high risk for infection too. But condom casts are an alternative for gentlemen. If you get them to stick okay, they sometimes help in a wound care situation. Otherwise, you might have to put an indwelling Foley in, and most gentlemen don't like that. Most women don't like it too, but mostly your gentlemen don't want a Foley. So those are some things that you can do to help with wound care healing too. Again, I will reiterate turning and repositioning, floating heels, extra padding on elbows, and then alternating pressure air mattresses are really good for people that in a home setting. It's nice because sometimes your caregivers are older and sometimes they're not able to do that turning and repositioning as well as a healthcare provider, a healthcare worker. And so sometimes those mattresses offer a little bit of help in those cases, in the home setting especially. And you should get those ordered the first time you start seeing skin breakdown on your patient, because they'll start going really fast. And again, I said I could talk about wounds forever, and I could. What are some products that you've seen that are really fascinating to you? Do you want to hear more about wounds? Let's talk about it. Cleaning wounds. Soap and water is good for skin. It's perfectly fine in the home setting especially. Wound cleanser is something that we use. Normal saline and sterile water is used in some situations. But you need to know, again, which wound cleansers, which cleansers that you're using for the wounds interact with which products, and you need to remember which products interact together adversely and can create more skin breakdown or more problems. Tell me about your experiences in the comments. If you're wound care certified, I'd love to pick your brain. Let's talk about it. And I thank you for watching. If you want to hear more and you want to see more, I ask that you like, subscribe, and follow, and I hope to see you soon. Thank you for watching. Bye-bye.